are live in Las Vegas. Thank you so much. We are at the huge MegaGen conference, and Dean, I got to tell you, these guys got the greatest speakers in the world from Korea, Israel, Germany, Portugal. Congratulations on getting asked to speak at this event.
Thank you. Very happy to be here.
So Dean Vafiadis, think of mafia with a dis. Dean Vafiadis received his dental degree in prosthodontic specialty training at New York University College of Dentistry. He is currently the director of the Full-Mouth Rehabilitation CE course at NYU. He is an Associate Professor of Prosthodontics at NYU College of Dentistry. He has lectured nationally and abroad for NYU. By the way, for those of you around the world, NYU is the largest dental school in the United States. 6.5% of all the dentists in America graduated from NYU. It's that huge. And he's the top dog there. Dr. Vafiadis published and lectured on various topics such as aesthetics, implant design, computer restoration, ceramic materials, and occlusion. He is the founder of the New York Smile Institute in New York. It is an educational center, full-service laboratory, and learning facility, as well as a private practice location for a multi-specialty practice for implant and aesthetic dentistry. Currently, he's lecturing for the Continuing Education program at NYUCD for dental districts in U.S., Europe, Asia. His patient base includes many celebrities, sports figures, Fortune 500 companies, producers, directors, and writers in the film industry, executives in the fashion world, world-renowned chefs and restaurant entertainers. He maintains his private practice. I could go on and on. He's got more initials after his last name than the alphabet. So what are you passionate about today? What are you lecturing about at MegaGen's Implant Symposium?
Well, first of all, thank you for what you've done for dentistry. I want to recognize that, and most of you who are on know that. You've changed the way people get information, so I appreciate that. The biggest thing that's happened in the last 3 years is digital technology. We've been a part of it about 12 years. So what we developed was a hands-on program for doctors to really get their offices, their techniques really honed in on digital technology using whatever scanner that they want. I have 5 scanners on the premises at my New York Smile Institute because I realized it wasn't about the scanner, it was about the information that's being transferred between the dentist and the laboratory. So if people have a scanner, I think the optimization of their use has really been limited because they were only learn how to do a single unit or a couple of units or maybe a bridge. Where now we've taken that digital technology and really expanded it to everything: diagnosis, abutment design, restoration, occlusion, and really changing the way the dentist is actually working in the operatory a lot less stress-free. It's a stress-free environment now.
So scanners, are you agnostic, or do you like some brands more than others?
Like I said, I have 5 scanners, different scanners in my office. So, and you say to me, a patient's coming in today and they want to get a tooth, and I want to prep a tooth, take a final impression with a scanner, I'll pick the trios. I'll pick a 3-shape. I'll pick a Carestream. I can pick a CEREC. I can make my own crown with CEREC. I can do E4, do anything I want at any moment in time, depending on what I have. If you're going to go with one scanner, you want to go with the fastest scanner that's most integrated with the most laboratories in the U.S., is 3-shape. I mean, right now that's the fastest. There's other ones coming up, by the way.
Are you concerned with the 3-shape Invisalign, AlignTech lawsuit?
No, I'm not concerned with that because I know behind the scenes. I know the people who are running both companies. It's just a marriage that's going to happen. It has to happen for us as the dentist provided for the patients. So if your practice is more of an Invisalign practice, you may buy iTero. If your practice is a restorative implant-based practice, you may buy Trios. At this moment in time, in 2018, the scanning technology is so accurate that it really doesn't matter. 5 years ago, it did matter. But to me, it's pick the one you like that you're going to be using in your practice on a daily basis, and then go with it. The critical decision is, where is your laboratory? Where are you sending that file? Because if the laboratory is a little bit digital and they're buying $20,000 printers as opposed to a fully digital laboratory which is buying a $500,000 printer, that's the difference.
Wow. That's profound. So are you placing implants or mostly restoring?
My first implant that I placed was 1992. So yes.
So you're placing and restoring?
Yeah, but I couldn't tell people that we were placing for the first 20 years. We had a prosthodontic referral practice.
Yeah.
So I couldn't, but today it's game on.
So what do you think the dentists out there don't know about placing implants that they should know?
Well, okay, so if you're a novice starting to place implants, you want to be with a company that is a digital technology company. So it's not just about the implant anymore. It's the system that you're going to purchase. This purchase this type of like MegaGen, BioHorizons. I mean, you have great companies who have a system behind them. It's not just the most expensive implant. That doesn't make sense anymore. Having the company that's world-renowned that doesn't service the customer. I want to be serviced as a provider. I want the company to call me. I want to have a rep on the premises. I want to have people there backing me up. Right? That's what you want from an implant company, but that has to be 100% digitized, and a lot of them aren't. So we kind of focus our doctors. We have a big course at NYU, a Full-Mouth Rehabilitation course, and we lead them into the companies that are leaders in the profession of digital technology and also have great implants with great success.
Now, you're 100% Greek. Have you
100% Greek.
Have you ever used Windex while placing an implant?
Well, no.
No?
But we do use peroxide. It's another great little technique that we use.
You hear people talking about up to 20% of implants have peri-implantitis after 5 years.
Yeah.
And some are saying 40% after a decade.
Okay, we're at less than 1%.
Why is that?
Because I understood the cementation process of an implant had to be perfect. I understood that the abutments had to be away from the platform. So if the implant's here and your prefab abutment is right there, and you miss a little bit of cement, you're going to have peri-implantitis. So when we started doing implant technology, 2004, CAD/CAM abutments, we made sure that our profile, which is one of the big things that I talked about today and tomorrow at the symposium, take the profile away from the implant, and now your cement is here. If you're doing screw retain, that's fine. But remember, the whole country was 80% cement retain, right? So if they were messing up, all of a sudden now you have peri-implantitis. If it's not correctly analyzed and correctly designed, your cement line's got to be away from your implant platform. That's the key.
So when you look at the implant market, a lot of lectures are the all-on-4s, these big heroic cases. But when you go into the labs, the majority of all crowns are done one at a time.
We're at 73% single units.
Yeah. So on your single unit, are you recommend cement or screw?
We're at 85% cement retain. We still do screw retain on certain cases. Our parameters for screw retain are short occlusal clearance, so less than 6 millimeters, you got to screw retain the case. The anterior implants that are placed lingually is going to be a screw retain case. But we're pretty much guaranteeing our position is going to be good, and we're going to probably go 85% cementable.
Can one system, for the general dentist, can one system be all they need?
100%.
And what system would that be?
I would say MegaGen. Right now, MegaGens are our #1 implant in our office.
And why is that?
3 main reasons. One, the platform is interchangeable through all the sizes. That's a big time saver when you're talking about parts and pieces. If you got 5 or 6 implants in a row and you got to keep changing the pieces, that's, for me, it's slowing me down. One driver, one screw, that was a big thing. The second thing, we helped develop their digital platform, so their scan bodies are super easy and super fast. Third main reason, 100% stability at time of placement. You got ISQ values at 72, 60 to 72 when you place that implant, even in a socket site. So to me, that's very valuable.
So are you what percent are you immediately loading?
Interesting question. So if you asked me that in 95 to 2005, we were about 80% immediate. You asked me that today, we're about 10% immediate. We've changed it. Why? In our practice, we're in Manhattan, we're in a very high, crazy patient base. We can't have a failure. So I can't take that 5% chance. So we're less than 1% because we're just being so careful. We can't have a failure.
Why is it that whenever I meet someone who's placed over 5,000 implants, they don't use a
surgical guide?
A surgical guide.
You got to have a surgical guide.
But like, I mean, we're at this conference, and a lot of 60-year-old guys that place 10, 20,000 implants and never replace. So why do you
they can't?
You're not teaching old dog new tricks.
You're a special doctor. You're a special person. I think I really work hard. Yes, I could do it without the surgical guide. But when you're talking to dentists who are coming out of school and we are the leaders of them, we can't tell them, oh, don't problem, I never did it and I never used it, don't worry, you're gonna be okay. You can't do that to the masses. You gotta teach them and put them in the right train. I always tell my doctors, get on the right train. At least if you get on the right train, you can kind of do it later, right? You can do it later, you can get off the train and get back on the train. Start with a good concept of doing dentistry the right way. I was taught with 14 prosthodontists that taught me, just get on the right train, do it right. Yes, you can deviate from the protocol. Yes, there's some cases you're not gonna have to surgically guide. But if you're doing implant dentistry and you haven't done more than 100, you got to do surgical guide. And think about the patient behind the wheel. The patient you're treating, come on, you can't try things and see if it works. You got to kind of know. Today, every patient is CT scanned. Yes, I can place it without a CT scan, but I don't want to. I don't want to have that error. I can't have that
What
chance.
CT scan are you using?
We have the Plan scan, Plan Mecca.
Plan Mecca.
Yeah.
Out of Helsinki, Finland.
Listen, right now, if you bought a CT scan today, they're extremely accurate. So again, I can't say one's better.
So you like the Plan Mecca?
Yeah, because it integrates with our scanning technology.
And you like the 3 shape, which is out of Denmark.
Yes.
So you're a big fan of Scandinavia.
I'm a big fan of what works.
Yeah, and Helsinki, Finland. I have a theory. I've been to these companies, Helsinki, Finland, for Plan Mecca, and Denmark, Copenhagen. My theory is that since it's completely frozen for 10 months of the year, they all tell you. I mean, they all tell you to your face. They say, I say, what do you do during those long dark winters? They say, we just work 10 hours a day, 7 days a week. They go, there's nothing else to do. Because I went to Creighton for undergrad. Okay. And it was so many times on a Friday night we had bad intentions and we wanted to go out drinking and crazy.
Beer?
Beer? Yeah. And
you drink beer?
And you look out the window and it's like sleet and frozen and we just say, let's just stay in and just study. And then the next day, Saturday, you had all these bad intentions of playing all day and it was just frozen. And then when I did my MBA at ASU and every day it was clear skies.
Well, you know what? It's time management. My son just started NYU undergrad. And it's time management. If you have a team, you have a sports team, you have things to do, I think you have to manage your time differently.
Yeah. So what do you cementing with?
Cementation. Wow, that's a big topic. So PFMs right now, we're still cementing with Duralon. Emax crowns, we're cementing with Reliex. And zirconia.
Wait, PFM, Duralon.
Duralon. Because it attaches to the dentin. The Duralon's a great, when it's mixed correctly, it attaches to the dentin. When we have a Emax crown, it's all Reliex bonded because it's 100% adhesive kind of crown. Now here's the trick, and there's a lot of different opinions about zirconia. Zirconia is not a real bondable restoration, and the companies will tell you it is. To me, I found when I cut off a zirconia crown, it just separates. There's no bonding strength. So it's still a metal. Zirconia is still a metal. So I treat it as a metal. So we teach our docs shoulder bevel, like a PFM, to have the closing angle, and then you can cement with anything you want. When you cement with a resin cement on zirconia, because the crown is not fitting exactly like a PFM or an Emax crown, it's a little bit dancing a little bit, that resin cement starts leaking over time. So I looked at some of my old zirconia crowns that had flat shoulder preps, and I got leakage. I was like, I got to redo that crown. Because the margin just kind of opened up because the fit wasn't perfect, because the cement wasn't really adhesive to the zirconia, I wasn't getting a good bond strength. And so now we changed our protocol to shoulder bevel. Now you can cement zirconia with anything you want. But Emax is Reliex. How do you feel about that with zirconia's crowns?
Well, the one thing I have on zirconia that I wonder is, when you look at 100 million insurance claims, it just bounces along and you get 4 big spikes on the 6-year molars. I mean, what tooth is most likely to be crowned, root canaled, extracted, replaced an implant? I mean, you got 32 teeth and the big spikes on it. Some of the endodontists wonder, back in the day, you bit down too hard, the porcelain would chip off the metal, the PFM.
Right.
Zirconia's not chipping.
Right.
So,
and it's also there's a little wear on the upper teeth, too.
And so it makes you wonder, is this going to be fracturing more teeth? And is a zirconia crown with no give, is that going to be a long-term better deal?
We're about 20% zirconia. We're about 60%, 70% Emax, and we're another 10, 15% PFM. The zirconia ones that we use, where I see the most benefit, one is anterior teeth for the color change, right? But we're still beveling, long bevels or shoulder bevels, because we got a ferrule effect, especially on the non-vital teeth. The non-vital teeth are so fracturable. They move a lot. There's mobility. If you can get a shoulder bevel or a long bevel on it, you're going to have a better closing angle with zirconia. So the color change is what I like to use, not so much the strength. For posterior, short teeth, we recommend putting a groove into the preparation, putting a bevel on the preparation. So you got to get a little bit more kind of solidifying the position of it, and then you got to check occlusion. Without checking occlusion to the nth degree of 9 microns, you're not really sure where you're biting down. So I think the bigger problem is occlusion.
Well, that leads to very interesting, occlusion is very interesting. I mean, I know I've said this too many times, but if I lined up 100 endodontists, they don't have that many controversies. If I line up 100 pediatric dentists, besides silver diamine fluoride, they don't really have a lot of controversies. But when these young kids are exposed to occlusion, it's kind of like world religions. I mean, you have, or should they be Buddhist or Hindu or Catholic or Greek Orthodox? I mean, why do you agree that the kids in dental school get more confusing information about occlusion than any of the other specialties? Do you agree with that?
Yes, I do, and I'll tell you what's going on. In the dental schools, the occlusal understanding of occlusion, it doesn't exist. Most dentists are kind of teaching what they were taught, and they were taught by somebody who didn't know what they were taught. Why is Frank Spear, John Coyce, Pankey Mann, and Dawson so busy? Why is our program in occlusion booked 2 years in advance? Because they're not being taught the right way. Now, I have doctors that go to these wonderful occlusion courses, and they come back to us and say, oh, this makes sense. You've narrowed it down to explaining the functional position of these patients, and we don't say CR is better than CO. We don't talk about philosophy. You know what we talk about? This is the patient that you're treating. This is the situation that they're presenting. How do you deal with that occlusion and going forward with single units or full mouth case or an anterior case? Here's the patient, analyze the patient. So we teach critical thinking, and therefore we're out of a dogma persona. We're in the, what's your dogma? You're a CR? Okay, let me show you CR in our situation. You're a CO? Let me show you CO in our situation. Let me show you MIP in our situation. Let me show you nethology, which I was taught with Frank Salenzer, Howard Litvak, Victor Lucia. I was taught nethology. We've taken it to a personal level, specific for that patient, and now the decision-making is very clear. And we have doctors coming in from Spear, great courses of Spear and Coy. I mean, those are my top guys. Great, great clinicians, right? Beautiful, beautiful documentation. And now we say to them, okay, you got that philosophy. Let us show you your practical dentistry application for your specific patient. To us and to me, that's the best education, because you're teaching them on Monday morning how to make a final decision. And that's critical thinking. That's what we're teaching.
Okay, so she graduates from dental school. Her mom's a dentist. Her dad's a dentist. She's in with her mom and dad now. And every time anybody has a TMJ, occlusion, anything, it's just the assistant comes in, takes alginates, sends labs, making up her tray. 2 weeks later, an upper tray is delivered. That's the real world for 90%.
And myself. I do the same thing.
What are your thoughts on
So, okay, so there's two kinds of patients. We categorize them as two kinds. There's the TMJ pain patient who's got some kind of formal joint position that's out of position, post-orthodontics, 20 years, right? Those are a lot of the pain patients. They have beautiful teeth straight, but they don't have no guidance. You have patients that are just myofunctionally in trouble. So that's a TMJ patient. What we do with those patients, biplate therapy, for 50% of them, 60% of them get okay, and the other 40% we send out to the TMJ specialist, right? So that's one category. The patients that come to us that I'm treating are non-symptomatic, grinded their teeth, they're all ground down, they're class 1s ground down, they're class 2s, div 2s in a position where there's grinding, or they're class 3s and they're protruding, but they're not in pain. So that's a different type of patient. So the patients who are in pain, yes, we'll treat them with the biplate therapy as much as we can, and then they go off to the TMJ specialist. So in our clinic and in our education, we don't treat people that are in pain. They get out of pain, and then they can come back for restoration. So most, I would say 90% of our patients, they have no pain. Even if they've worn down their teeth, the dentition is really worn. Remember, their teeth took the burden. The joints are stable, the tissue's stable. Their teeth just got worn down. So now we just got to restore the teeth.
Some occlusal camps need $10,000 or $15,000 machines to supplement the occlusion. Are you big fans of any of those?
No, not at all.
So you don't need any T-scans or...
Oh, T-scan's great. Hold on. T-scan's great. What does T-scan do? T-scan gets us confirmation. So watch this. Patient comes in, and you can go on our website, nysi.org. You can go to our fmrnyc.org. That's our course. We have a lot of photographs. fmrnyc.com. And then you have fmrnyc. That's a different one, .com. That's our course. That's photos of class 1, class 2, class 3 cases. So going back to your question, we take the patients where they are, we analyze them, put them in a decision tree, and start treating those patients a certain way. That makes it more personal for that patient and their jaw position and where they are. So that allows the dentist to make a better understanding, critical thinking of what they have to do for that patient. I don't know if that makes sense, but it's just more methodical the way we approach the patient.
These young dentists, when you got out of dental school, what year did you graduate?
89 dental school, 91 pros.
Okay, 89. I was 87. That's why you look so much damn better. Those 2 years. These next 2 years are going to be hard on you. You're going to look like this in 2 years. They're coming out with a lot of student loan money.
Yeah.
So a lot of them always wonder, what do I have to buy to be as good a dentist like you? I mean, do I got to buy?
No, I disagree. They got to buy education.
So do they need chairside milling?
Yes.
Or can they use a lab?
No, I would say if the first 5 years, 7 years out of school, you got a lot of loans to pay. You got to work. This is my formula for my young docs. We just did a course for Columbia NYU just like 2 weeks ago. And I said, these young fourth-year dental students are graduating for $400,000, $500,000 in debt. I said, what's your 5-year plan? Forget about later on. 5-year plan. You got 6 working days. You got 1 day for your family. You got 6 working days. 1 day is for education. Period. Your Wednesday or your Friday is for education. You got 5 days to make money. Go to a clinic, go somewhere, go to make a job, go to get your money. You got 2-3 days to make money. Get another office that's a really high-end office. Work there for a day. Even if you don't get paid a lot of money, learn from that doctor. Have a mentor. Come to NYU. Have a mentor. Go wherever you are in your facility and have a mentor that's teaching you the business of dentistry and the practical use of materials, because out of dental school you don't know. So you got really 4 really hard working days to make your loan payments, to make your apartment payments, to take care of your needs. But if you can stick on that plan and always have that 1 day of education, you will be on the right path in 5 or 6 years when you can buy a practice, you can join an associate, you can join a team. But having that 1 day of education is going to keep your mind growing. The education process in dental school just gets you started. It's necessary. But that's the base. Now you got to grow, you got to grow, you got to grow. So education is the number where you're going to spend your money.
But go back. You didn't answer the chair side, the CAD cam.
Okay, chair side CAD cam.
Yeah, because some things like we notice on Dental Town, like if you're looking at bonding agents, well, that's a very different length of time than if you're looking at whether or not to buy a CEREC machine or a CBCT.
Yeah, but why would you go? Why would you? Okay, let's go through that route. Let's say I'm 3 years out. I'm making some money. I'm working a couple clinics. Buying a CEREC machine is not going to change my practice patient experience. Really, it's not going to really do that. It's not going to get me faster. It's not going to make me more money, really. I got to get proficient in my dentistry, and I'll learn the digital technology in my learning courses, all right? And then when I'm ready to buy my practice, or I'm ready to be a partner, or I'm ready to expand, that's when you buy the CEREC. That's when you buy the milling machine. That's when you buy the scanners. So to me, you got to get proficient in dentistry.
So in answer to your question, they don't need to buy $150,000 CAD camera.
I don't think it's going to make them more money.
Right.
They need to make more money at that point. And learn, right? They got to make money and learn.
Same question about lasers. A lot of people think they need to buy expensive lasers.
It's going to help them be a better dentist, but they got to learn the dentistry.
Right.
I tell my docs, where are you at? I'm saving 8 years out. Okay, you got some experience under your pocket. Okay, now that's the next step. You're in the 7-year mark. It's time for the next step. Buy a practice, associate, buy a machine, because you're at the next step. The first 5 years, you know that, Howard, they got to just learn. Just not learn to do the dentistry, just whatever it is, just learn it.
Yeah. Do you think you've been in Manhattan practicing for, 30 years?
I started in 1990. I started my first office. I had one patient.
So 28 years. Yeah. Do you think 28 years from now it'll still be a market where private fee-for-service dentists will thrive, or do you think DSOs and chain dentistry is coming into Manhattan?
I have a little bit of experience, very little bit, 2 or 3 years that I've been searching out the DSOs. I think first and foremost, which city or what state you're in. It's a very different stratosphere if you're in Manhattan and if you're in somewhere in Oklahoma City or somewhere, maybe Idaho. It's very different, very, very different. Each city is so different. So I think if you look at the main cities, the NFL cities, let's say, the NFL city that is really popular, I think fee-for-service will always be there. I think there's a market for the DSO companies to get the young dentists to work for them, and they need help. They're providing a service, they're providing financial help for these doctors. But it really depends on where you are. So the first question is, where are you? Where are you practicing? What's the demographic? I'm sure you do demographics all the time where they are. And then it's the best decision of which is the best decision for me. Fee-for-service, I think, in Manhattan will always be there.
Do you think the implants extincted the Maryland Bridge?
I think implant dentistry has extinct periodontal disease. We solved periodontal disease, didn't we?
No.
Yes, we did. It's still
treating it with extraction?
I'm sorry?
What do you mean?
Yeah, they take out the teeth. nobody's treating perio. We still treat perio. I was taught periopros. I still treat perio. I save the teeth. I save the teeth. I save the teeth. Everybody's taking out teeth. I think it's horrible. I don't like that. I see it all around the Facebook, and they're just taking out teeth, putting 5 implants, and calling it a day. I don't think that's really the way to treat people, because they're putting them in a box. They're not really taking care of them. So for me, it's, you got to take care of the patient first.
A lot of people are in this mindset that Emax is only strong enough for anterior and you got to go zirconium in the back. Do you think molars really have to be zirconia, or do you think Emax is?
No, again, I'm on a different train. My train is critical thinking. What does the person have? They have a grounded occlusion, and they're wearing their teeth down, and you're making one tooth in a really bad environment. Okay, you're going to use zirconia. You have a good system that's working. There's only one tooth breaking. She's 35 years old. It's a beautiful tooth. It's an anterior tooth. It's a posterior tooth. You're going to do an Emax. It's going to look better. It's going to be beautiful. It's going to wear really well. So I think, again, looking what you have, instead of putting your patient into the zirconia box, put the zirconia where it belongs. Put the Emax where it belongs. For the anterior aesthetic veneers, we use feldspathic. My teeth are feldspathic teeth in the anterior. Right? They're perfect teeth. They look gorgeous. So for me, look at the situation and make the right decision for the patient. If you're in a clinical environment and the doctor's not allowing you to make those decisions and everybody's in zirconia, listen, you're going to do what the doctor's telling you and you have no choice. But if you have a choice and if you're thinking smart, you're going to take care of your patients. Don't sell a patient to the material. Make the material fit the right patient.
Nice. One of the biggest partial labs in the United States of America is, I'm in Phoenix, Arizona. And you drive down to the Mexican border, Nogales, Arizona, all the partials are shipped there. And they drive into Mexico, and there's a lab down there that makes about 1,000 cast partials a day. 1,000 a day. And I drive down there, 90% of all the incoming partial impressions, they didn't even cut a single, they just said lower partial. Not one.
No preparation.
Nothing. 900 a day is just, here's an impression that says lower partial. Is that a little lame? I mean.
No comment.
No, I want you to comment. I know you comment.
Listen, I understand there's financial burdens. I get it. But I think the education process, again, for a partial denture, I did partial lit review for NYU for 4 years. We went through hundreds of articles of how to design the partial to make it fit for the patient. And it's not even the preparation that was so much necessary, just the design. Just understanding how the design really works, the fulcrums and the points. So yeah, I get it. Look, there's a minimal amount of time, there's a minimal amount of money in a certain clinical scenario, and they just don't have the time to do it. I understand that, I'm empathetic to that, but there's got to be a consciousness for the doctor to say, hey, let me just think this for 5 seconds and say, let me put a couple of rest seats here, change the profile, and then take the impression. It can't be that hard. And if you're not sure of it, then at least ask a mentor and say, help you with removable. Look, RPD is a big factor to help people. They have no teeth. They got to get something in there. So it's a big resource to help patients have teeth.
A lot of the young kids are getting conflicting information. When is a quadrant tray okay? When do you need a semi-adjustable articulator? When do you need a face bulge?
The decision of, it's a long question, but I'll try to shorten it up. If you have a posterior natural tooth and you want to take a triple tray, I don't have an issue with that. If your posterior tooth is the last tooth in the quadrant and you're taking a final impression, you got to take a quadrant, you got to take a vertical bite, because when they're mounting that case, there's a dip, there's a movement in that mounting. If the tooth is there and you're doing 1 or 2 teeth between the 2 teeth, then you have at least a stable bite. So it has to do with what teeth are in the neighborhood of quadrant dentistry. In terms of face bows, we're on the right side. What we say is anything over 6 units has to have a face bow. We use Artex face bow from Jensen. Artex, A-R-T-E-X. If I told you that I can teach you how to take an Artex face bow in 90 seconds, would you do it on every veneer case? Would you do it on every wax up? Would you do it on every full-mouth rehabilitation? Would you do it on every implant case? Full arch? Yeah. But because it's taught in a way that it's cumbersome and it's 40 minutes or it's 30 minutes or it's an hour, you can't take a face bow an hour. Nobody wants to do that. But if I can do it in 90 seconds, absolutely I'm going to use it.
Some people say a post adds retention to the crown. Other people say the only function of a post is to fracture the root. Do you do less posts today than you did 30 years ago?
No, I stopped doing cast posts because of the fracture potential. You really can't figure out what your stress levels are, and I had a lot of failures in the beginning of my career. Doesn't mean they're bad, and you have to do it the right way. So technique is really, really hard with cast post. So we believe in the flexi-post system. Every tooth that's root canaled gets a post. I'd rather have a steel piece in that tooth than a hollow gutta percha or some kind of, material down in the canal. So we put a post in every core and every root canal tooth.
When I got out of school 30 years ago, they told me that dentures would go extinct. And when I look at the macro data, we did more dentures in 2015 than we did in 1985.
Right. And I think that's because of patient awareness more than anything, and availability. I don't think it's because the denture was no good. I think they realized they can get teeth in a day, or they can get teeth, they can get it faster, easier, cheaper. Insurance is paying for it. So you're going to have an increase of denture prosthetics, but not because there's more patients, because it's more available, I think.
So
Does that make sense?
Yeah. So I want to switch from fixed pros to removal pros. 2 questions. How many appointments can you get your denture down to? There's people that start at 5 and try to get to 4 to 3. And now we have digital dentures coming down the pathway. And some of the digital denture people think that someday they're going to get down to 2 appointments. So are you I'm sure if anybody's looked at digital dentistry.
I'm not qualified to answer that because I only do maybe 1 or 2 dentures a year. So I'm not really qualified to tell you.
And why do you only do 1 or 2 a year?
It's just the population that we're in.
Manhattan.
Yeah, there's nobody who's got missing teeth, full arches, so we don't see that. We see it more in the clinic at NYU, but even there, it's, I would say, 5 a year. So I'm not really a good person to ask that. I don't do 1,000 dentures a year. But I will tell you that the digital technology, it still comes down to the impression. If you get a good impression and you know how to take an impression, everything's going to go a little faster. When I do have a denture that I'm making, it's 5 visits for us, pretty much guaranteed 5 visits. Maybe 6 visits if it's a very high aesthetic patient. But I think dentures are here to stay. They're going to be very successful. It's going to be easier for the novice to do a denture at a high level. That's what that's going to happen. You have a novice doing a denture at a very high level, and that's a good thing for the profession.
I see dentures around the country exploding also following the meth epidemic. Like you go to California and you talk to all the dentists there that are my age, who practiced there for 5 or 10 years, and you almost never did a denture, and then meth hit Bakersfield, and then every dentist was doing a denture a week. I saw that in Phoenix where I can still remember in the early 90s, and when I was in college I'd never heard of. No, the meth wasn't a thing back then. And the bad boys smoked pot or did Jack Daniels.
Or drank beer.
And then all of a sudden, out of nowhere, you just had these people just losing.
I don't see that where we are, but I'm sure NYU would be a better caliber.
So it's really the heavy meth areas. So amalgam. I mean, it's the most controversial thing. I just want to tell you my rant before. It seems like when I got out of school, it seemed like restorations last longer. I mean, they were amalgam. Amalgam's half mercury. That's antibacterial. The other half is silver, zinc, copper, tin, silver diamine fluoride, tin, stannous fluoride. I mean, everything in an amalgam is not found in a multivitamin. It's just, And then we replaced it with these pretty tooth-colored fillings. And when I got out of school, all the guys that were my age when I got out of school said, look, I removed this amalgam and there was black scuzz underneath it. How horrible. Now I'm bonding in clean composite. I'm bonding all the was. I'm telling you, when I remove a 35-year-old amalgam, there's some black scuzz underneath there. 6.5-year-old composites, it's oatmeal. I'm in there with the number 4 round burr taking out crap.
So that's I think it's an issue for the technique. As good as we think we are, maybe we're not getting bond strength to the enamel. Maybe the enamel's not good. Bonding relies on enamel. If the enamel is not really good and we have no way to identify good enamel and bad enamel, you're going to get leakage. So I can't do an amalgam because no one's going to allow me to do that. So I haven't done amalgam in 15 years. But I'm really careful with isolation. I'm really careful with analyzing, trying to figure out, is this enamel going to be good? How's the occlusion? Again, back to occlusion. If you don't eat, it'll last for 15, 20 years. So how do I change the occlusion to help my bonding? So I'm trying to do everything I can to make those survive. But we've definitely switched over to more of a scanning, get an inlay, get a Emax inlay or Emax onlay for a little bit better, survival rate.
Do you think an MOD inlay onlay milled porcelain would last longer than a direct composite?
I think so. And also the new ones that are composite mills are really good materials. So I'm seeing much more success with that. I'd rather scan it and mill it. Even if we charge the same amount for the composite, I know it's a 2-visit procedure, but I think long term, I think it's a better restoration.
Are you doing any gold inlays onlays?
I did, I must have done over 1,000 in my career.
I mean, all of mine are gold.
I haven't done it gold in about a year or two. I have a couple of babies that still want gold. It's still, the standard in terms of integrity and marginal integrity, but I haven't, people don't want it. They just don't want it.
Yeah. So what would you say, podcasters are devoured by dental students? I mean, send me an email, howard@dentaltown.com, and tell me how old you are and all that stuff. But about at least...
Can you give me my email, because I'm sure they're going to have questions.
Yeah.
drdean17@gmail.com, drdean17@gmail.com. If you have any questions or want to look at the course, or even if you want to come to NYU just for the day, or you want to just fly into New York City and spend a day at our practice, we open up our practice. I want you to know that. To all our colleagues, all our dental students, all our people around the world, we open up our office so people can see and watch. That's how I learned. So I open my offices to people, just as long as they schedule and they come.
And the website you recommend is the FMRNYC?
.com, yeah.
Which stands for Full-Mouth Rehab, New York City. Full-Mouth Rehab, New York City. FMRNYC.com. And his email there is FMROcclusion@gmail.com.
But personally, drdean17@gmail.com.
drdean
17
at
Gmail.
And you got to tell him what 17 meant. It's a mnemonic device.
When I was 17 is when I went to the dentist and I had broken teeth, and he told me I had to spend $600 for 2 teeth. I didn't have the money, so I assisted him for about 3 years and got into dental school. I was 17.
Nice. That's very, very meaningful for you. And on your, if you go to FMR for Full-Mouth Rehab, NYC.com, you have occlusion course. Tell them what they're going to find if they went to FMR NYC. What are they going to find on that website?
Well, the best thing about that is to find a mentor, find a occlusion course at NYU that we teach, and getting doctors into a better level of education for themselves, and provisionalization, aesthetic dentistry, doing veneers, doing things the right way, the techniques. So it's a course that allows us to really teach you hands-on of how to do great dentistry and be a great dentist and get on the right train. You got to get on the right train with the right mentors to be successful in dentistry. It's a tough profession, and doing it right with education, I think, is the way to go.
Now, are you the owner of FMR NYC?
We have 15 faculty members that we all part of that organization.
Wow, this is in Manhattan.
Yeah, and New York at NYU.
But
The course is given at NYU.
And are they 1 day, 2 day? Talk about.
There's 4-day courses in October and in May. It's 4-day courses. For people in the surrounding area, we have a Friday course. It's every Friday.
So it's a 4-day course in October or
May.
Or May.
Yeah.
That is so beautiful. I got to tell you something. Yankee and Chicago, every year, every time we go to Yankee or Chicago, they're always complaining about lowering attendance, all that kind of stuff. It's like, dude, your meeting in Boston is in February.
It just makes sense.
Greater New York. The Greater New York meeting is the
November.
greatest meeting because it's the weekend after Thanksgiving.
Yeah.
And there's nothing more fun than Manhattan in October, November.
Yep. And December too. December's awesome.
And December. And then you go back to Chicago Midwinter and you say, I mean, when you get out of the cab and run for the door, when you still get there, you're still like
freezing.
Your body hurts, and you say to everyone there,
why are we here?
why in God's earth do you have this meeting in February or March?
Somebody
Somebody
started it.
Yeah, we've had it this time of the year ever since 1880.
You got to change, ladies and gentlemen. You got to change.
It's like, so what?
Because I was just in Chicago before this meeting.
Yeah.
Beautiful. Chicago in October is
Oh, I
beautiful. It's
know.
gorgeous. It was 65, 70 degrees.
Yeah, I like going up there on St. Patty's Day when they turn the river green. I mean, Chicago
I
and
love
Boston.
Chicago. I love Boston, but I'm not going in.
I know,
between
God
December and
dang.
March.
So congratulations on having your 4-day course in October, which
May. New York City in May.
And
It's
try to
awesome.
lean on your dental meetings. Like, sometimes a tradition is a good thing, and sometimes it's been a bad idea for a century. And I love Chicago as much as anyone on earth.
Well,
but I cannot stand
I want to
Chicago.
formally invite you for the May course, and I want you to come and speak to the doctors about, whatever you're doing with dental.
Well, you know what?
I really want to invite you. I really want
you know what? I think the best marketing for your course would be is put an hour online CE course on Dentaltown.
Okay.
And we put up 400 one-hour courses. And gosh darn, I've had so many people.
What if I told you I have an hour webinar that I can give you today, and you can put it up
That would
on occlusion?
Oh my! I would love it.
I'll give it to
and
you.
it would give our CE so much credibility to have someone of your
100%.
caliber.
100%.
Yeah, I would really love that.
A lot of our faculty are in Dentaltown. I mean, they always tell us what you guys are doing, so we're all in with that. We love education.
Well, if you're under 30, you're on Dentaltown and Instagram. I mean, they do everything on their iPhone.
Our Instagram is Dr. Dean 007.
And where'd that come from, Dr. Dean?
I also live dangerously.
Well, I would love to have. And if you put up that course, the Dentaltown magazine goes to 125,000 people. So if you put an article and the online course, that 1-2 punch.
I have an article to give you too.
My gosh. Thank you so much for all you've done for dentistry. Thank you so much for coming on the show.
Thank you.
And talking to my homies.
Awesome. Thank you.
All right.
Enjoy it.